It's a pleasure to welcome you here again today for our meeting, and I'm gonna hand over immediately to Anne John, who's going to open the first symposium on underserved and underrepresented populations. Cheerio for now.
Thanks, Andrew. I guess one of the things that the last year and a half has done is thrown into, a real spotlight the inequalities in health that existed pre-pandemic, but people have become really aware of since. And for me, I'm public health trained. So I'm a clinical epidemiologist. I've always focused on inequalities and what we used to call vulnerable groups. And so I'm really pleased to be chairing this symposium on underserved and underrepresented populations. I'm now going to introduce Sarah Rees, who I work with very closely. She's a senior data analyst at the Sale Data Bank in Wales, and we, for the past couple of years, been working on a project related to the Gypsy Roma traveller community, led by Professor Louise Condon. So over to you, Sarah.
Okay, so I'm just having some problems with my mouse. There we go, right. Okay, hello everybody. My name's Sarah Rees. I'm an analyst at the Secure Anonymised Information Linkage Data Bank, or SAIL Data Bank. And this is a bank of health-related data that's available for researchers to use. I'm also part of the Adolescent Mental Health Data Platform, or ADP. And this is a specialist mental health research data source where data sets are available to specialise in mental health research into children and young people. So the project I'm going to talk about today is looking at routine data in the context of Gypsy and traveller health. So what we really wanted to do was to see whether it was feasible to use the routine data available to us in the ADP to carry out needs assessments for children and young people living in Gypsy and traveller sites. So the reason that we chose to look at this community was that we know that in general, traveller health is poorer than the general population. Less was known about mental health, and in particular, there was little evidence around mental health of children and young people. And as well as that, we know that historically, there was a difficulty identifying people from the Gypsy traveller community in routine data sets, particularly in health data. There wasn't a variable which distinguished Gypsies and travellers. That is starting to change, particularly here in Wales. We do now have a way of recording it in data, but there's very little going back more than about a couple of years. And I was reading a paper by the House of Commons Women's Inequalities Commission looking at tackling inequalities in this group. And this quote really jumped out at me. And this was a statement made by a specialist nurse working with the Gypsy and travellers. And she was saying, well, you can't commission for what you don't know, and you can't make change until you can prove need. So bearing all those things in mind, we knew that we needed a different approach. So we have the data in the ADP, and we also have available to us a biannual caravan count, which is carried out at local authority level and compiled to provide a resource across Wales, which maps out where people are living in caravans and on Gypsies and traveller sites. It's carried out twice a year, once in January and once in the summer. And this is reflective of the seasonal movements for this very mobile population. So what we wanted to see was whether or not it was feasible to combine these two data sources, so the ADP data and the caravan count, to enable us to support some of this type of needs assessment. So moving on to the caravan count and the data that was available to us, looking at the most recent pre-pandemic caravan count, there were 1,092 caravans in total, identified across 136 different sites across Wales. So the map here, you can see that they're not evenly distributed. There are pockets of them down in Pembrokeshire, up in the northeast, and then across South Wales. So there are these pockets where there are lots and lots of sites, and then some where there are none, and it's quite different according to local authority, and provision varies according to local authority as well. So of those 1,092 caravans, Most of them are on authorised sites. So this is where there's permission from the local authority for the site to exist. It's a combination of private and public provision. There are a small number in the most recent count, it's about 120 unauthorised sites. So these are where there isn't that permission from the local authority, and this could be a site in somebody's field, it could be a couple of caravans by the side of the road. So there's quite a lot of variation in what that actually means. So we got data on sites that were part of the caravan counts from 2012 onwards. And what we could see over that time is there was a huge increase in the number of authorised sites that were detected in those counts. So it doubled in that period. The number of unauthorised sites remained quite stable. However, it's likely that there was a turnover of sites, and it's not the same sites that appear in each year because they are quite transient. So the total number in there will be much greater. So as part of our project team, we had a geographical information systems specialist working with us. And so the first part of the project was really getting the data that we needed in order to identify the individuals in our data sets, but in an anonymised way. So he took the postcodes that were very kindly provided to us by Welsh Government, and he mapped them. So in this photo, you can see a blue hexagon, and that's the postcode centroid. The orange dots designate all of the unique property reference numbers, or UPRNs, that exist within that postcode area. So what he then did is he took these UPRNs and just looked to see which ones were in the proximity of Gypsy and traveller sites. So that then created a list, excuse me, it created a list of UPRNs, and we were also able to attach a site type. And this was a descriptor of the kind of site that we were seeing. So it might be that it's a semi-detached house or a maisonette. There's also a category for caravan. So we wanted to focus on ones where the site type was caravan. So the next step for us was taking this list of UPRNs and then making it usable for us in Sail. So obviously the UPRN is identifiable. Our data are all anonymised. So we convert to what we refer to as the residential anonymous linkage field, or the RALF, and that is the kind of common language for Sail. So that's our address identifier within the Sail and ADP data sets. And what the next step that allows us to do is to link all of the people that have got a record associated with this RALF. And we can do that through the GP history that we hold. So each GP record, we can see where somebody has lived. So we have a record for each residence period, and that's got the RALF attached. So we now have a list of RALFs associated with traveller sites and a list of anonymous linkage fields, or ALFs, which show the individual people that have resided in those sites over time. So moving on to our study cohort, we had quite a broad definition to identify our study cohorts. We felt that any period of time resident in one of these sites designated being a member of the Gypsy and traveller community. They're quite insular. It's not somewhere where people are just moving in and out from outside the community. So as long as somebody had got a record at any point in time while they were under the age of 18, we included them in our cohort. And then we linked to our health data sets, which were the primary care, so GP contacts, outpatients, accident and emergency, and inpatient data. And our conditions of interest were common mental disorders. So we looked at anxiety and depression. And then we looked at self-harm as well. And we used code lists that pre-exist and have been validated and published by work carried out within the ADP as well. So we were using these pre-existing concepts to define our conditions. So the measures that we used were incidents, and we looked at first annual incidents, the first occurrence of an event within a 12-month period. We were also interested in a couple of other things as well. So we wanted to know if we could identify people that had only had a prescription of medication but hadn't then had any other contacts. So we looked at that. We also looked at not attending or DNA rates in outpatients. And we compared the Gypsy and traveller cohort with the general population in Wales. So just moving on to our findings. So we found 344 addresses that were designated as a site type of caravan. And there were also an additional 34 where we didn't know what the housing type was. The site type was authorised private. So we weren't sure about these ones. And our GIS specialist went and had a look and felt that it was quite likely that these were also Gypsy and traveller sites. So we've got this 378 RALFs. From that, we then extracted the individuals, and we could see, so we tested out the 649 ALFs that we obtained from the definite caravans. And we also looked at including these unknown ones, and that gave us an additional 150 or so. So we compared the results for both, and they were both very similar. So we decided to use that 802 after carrying out the sensitivity analysis. So the first thing we did was compare what we were finding from our Gypsy and Traveller cohort with the general population of Wales. So what we found was that in general, the Gypsy Traveller cohort was considerably younger. So around 50% of our cohort was 11 to 17, compared to about 42% of the general population. They were much more deprived in terms of the Welsh Index of Multiple Deprivation. So 60% of our records were residing in the 40% most deprived quintiles. Although I think it's important to mention at this point that this is an area-based measure of deprivation, so it's not reflective of individual levels of deprivation. What it is showing is that these sites do tend to be located in the most deprived parts of Wales. And one other interesting observation that we don't have an explanation for was the fact that there seemed to be quite an imbalance of sex. So we found that there was a much greater proportion of males than females. So we went back to the census to have a look at this, and actually that pattern's replicated there as well. So it was an interesting observation more than anything else, but not one that we can explain. And just moving on to our results, we ran a series of Poisson regressions to derive instant ratios for our different measures. And looking at this figure, we looked at common mental disorders in primary care and inpatients. We then looked at self-harm in primary care, inpatients and A&E, and we looked at outpatient attendances. So for outpatients, we weren't able to get right down to the level of clinical coding because the coding just isn't there. So we had to look at outpatient attendances under psychiatric specialties. And for A&E, similarly, we were only able to look where there was a code indicating that it was for a psychiatric related contact. So we didn't find any significant differences in our contacts with services. We did, however, find significantly greater rates of not attendance, particularly in follow-ups. So the rate wasn't significantly different for new appointments, but there was a significantly greater DNA rate for follow-up appointments. And we also found that we were approaching significance for our contacts where someone had received a prescription of a medication from their GP and then had no other contact with any services. So obviously we're not really able to draw too much from this because our results were not significant, but as a general observation, we did note that the contacts that indicated perhaps better managed care tended to have lower rates among the Gypsy and Traveller population. And those types of contacts, such as attendances at A&E, which might indicate a less well managed or much more kind of on an emergency basis, were higher among those populations. So that's something that we're going to try and explore a bit more. So that's the results of our study. Just going to talk a little bit about some of the limitations. So there is a concern that the UPRM method may lead to inclusion of some false positives. So because we're looking at the general area, if a house is nearby or there's another property nearby, there is the possibility that we might have included that erroneously in our cohort. However, inclusion of the site type should help us to minimise that, but there is still the risk that there might be incorrect designation of some of those site types. Importantly, because we had to exclude the unauthorised sites, this is because they're not even really addresses as such, so there isn't a UPRN to identify for them. So we are looking at just a subset of the population. It's also quite difficult to validate against the official caravan count. So we know that there were these 1,092, for example, in January 2020, but it's not always clear whether the UPRNs designate an entire site, so it would be a number of different caravans, or if they're a specific, a single caravan. So it just makes it difficult for us to be confident about the proportion of the population that we are actually capturing. And a key issue is that we're dependent on GP registration. So we need to know that somebody's registered with the GP and they've given a site address to their GP practice. So we can't find anybody that is not registered with the GP, which we know is a significant issue in this population. Or if they're registered elsewhere, either they're registered with the GP outside Wales or they're registered under a different address. And we're also not able to capture gypsies and travellers who are resident in other types of accommodation. So say, for example, bricks and mortar housing, and we know that that's a large proportion of the population. And this prevents us as well from being able to look at potentially interesting areas such as ethnic density effects, where people fare better when they're in less of a minority in their living arrangements. So just to conclude, cautiously, I think we can say it is feasible to assess the needs of a subgroup of the population that we're looking at using these methods and using routine data. And there is now a data set available, so the RALFs that we've generated through this project can be used by future projects as well if they want to look at the same population. However, as I've talked about, there are quite a lot of caveats around the population and how representative it is of the wider Gypsy and Traveller population. Particularly the issue around Welsh GP practices. So one of the things that we're hoping that will be available in the future is that the RALF will be available in some of our other data sets, which would take away the dependence on the GP practice. And in particular, we really want to see that in our emergency department data set, because we know from other evidence that this population is particularly reliant on emergency services. We are hopeful that some of the differences that we're finding may be indicative of genuine issues to do with access. So we know that it's very difficult sometimes for people from Gypsy and Traveller communities to register with GPs, particularly if they're vulnerably housed or if they're no fixed abode. There are concerns as well from the population around cultural sensitivity of services, and then some fear of discrimination as well. And then even within the community as well, there are potential concerns about stigma around mental health as well, and a general reluctance to present until things have reached a kind of crisis point. So there's some interesting pointers for us to follow up. So that's it from me, but just to make some acknowledgements. So this project was funded by MQ. It makes use of data that's held in SAIL and the Adolescent Mental Health Data Platform. And also just to say thank you to Annie Crocker from the English Romany community and Denise Barry from Travelling Ahead, whose input has been really, really vital. So that's it from me.
Thanks so much, Sarah. I guess sometimes when I'm hearing people present data linkage studies, I'm always struck by how it sounds like it was so simple. I think Sarah sort of easily went over all the really technical work that went into creating this data set. We've had a lot of questions through that we'll answer in the Q&A panel at the end, so I haven't forgotten them.